Welcome everybody. We'll go ahead and get started with one of our afternoon sessions. Just in case you wandered into the wrong room, this is Remediating the Struggle Learner and looking across the educational curriculum. We today aspire to some disclosures, and we'd like to focus on a couple of different case-based approaches to learners who are struggling in different areas. We're going to focus on recognizing, gathering information to develop a framework that parallels a little bit of differential that we might use for clinical problems, and then focus on remediation plans and local resources to help that. And lastly, with each case, we'll discuss anticipated outcomes of remediation. We're going to work through 4 cases today that begin with medical students and actually finish with faculty struggling in their careers. Please stop us if you have questions. This session is being live streamed, so if you do have a question with us, either raise your hand and we'll get you a microphone, or come up to the microphone in the center and ask. Why is this topic important? I think it's important to a lot of people. It's important to the learners themselves, but it has huge impact to the entirety of our programs: faculty satisfaction, fellow learners, and really thinking about our overall obligation and workload that we're managing. When we think about our learners having difficulty, we know pretty well from past literature that recognizing some problem exists is not the problem. Understanding what that problem is really crucial. And so diagnosing correctly what our learners are struggling with so that we can create an intervention plan is the key focus that we'll take a look at. So we'll begin our first case with a medical student.
All right, good afternoon, everyone. So we're going to talk about case C to start with. So she is a student who joins our EM rotation in her 3rd year of medical school. And what we notice about her when we were getting evaluations back is that everyone really absolutely loves working with this student. The patients love her. You're getting great feedback from the patients. The residents are already talking to you about how do you recruit this student to be in the residency. She's just an excellent team member. She's always willing to chip in and help with things. You know, you notice that sometimes as she's presenting things that she doesn't always include all of the relevant information, but you're not really sure, is that because she isn't sure how much you want to know? Is that because she doesn't know what's important? And her differential tends to reflect some of the common etiologies, but she's not really great at being able to prioritize and to rank order these. And then she tends to sometimes just skip over the differential and really think about, here are the tests that I want to order, as opposed to why she wants to order them. So after your clerkship ends, you note that she has failed her exam, and you can't really give her the grade that you want to. You're really anticipating that based on all of this feedback that she's going to be an honors or high pass student, but instead you find out that, that she's failed the exam and you're going to have to work with her. And then when she comes to your office, she really describes that she is tearful, she's upset, because this has really been a challenge for her. So she's a non-traditional student. You find out that she's come back to medical school and really kind of struggled in the first 2 years. And the patients have always liked her and given her that feedback in the first couple of years. And so she really anticipated hitting her stride when she hit the clerkships. And it just really hasn't happened quite the way she imagined, especially when this is her 2nd failed shelf exam that she's going to have to remediate. And so then you start to look at, comments from other clerkships and find out that, again, that everyone really loves working with this student, that she's motivated, she's a team player, the patients adore her, that she's compassionate, but you notice that there's a couple concerns as far as maybe she's intimidated, she's really working to develop a fund of knowledge, but there's probably some consistent fund of knowledge problems here. And so you're really tasked with, how do you help her? So is this a problem for the learner? What additional data do we need? And then how would we formulate our differential? Because we really can't come up with a plan of how to help this individual student if we haven't really keyed into what is our underlying issue. And so this is a hard one, because I think for students, we really have to think, we are sometimes so siloed in our approach to this student. We know what they disclose to us, but we don't really have a picture of the whole story. And so thinking about this, you really have to be able to leverage your resources. But thinking about some of the things that may help answer this is really, why did she struggle in the preclinical curriculum? What were her grades? Did she struggle on multiple choice tests? Is this something that's been a pattern throughout her educational continuum up until this point? Did she have to take extended time to study for step 1? how is she using and performing on self-assessments? Because there are many more self-assessments out there to help students really gauge. And how is she studying? Is she using Anki cards all the time, or is she really actually engaging in active learning and feedback? And how does she really perform in the clinical setting? Is there OSCE information that may be able to help us? And so in talking with this student, what we found out, I think, is that there's really probably some medical knowledge deficits with this student. The student has struggled along the way, and so you really have to think about, are those deficits really compounding over time? Does she actually have a learning disability? Does she have undiagnosed ADHD, which is something that we actually see pretty commonly in students, that our students are so incredibly bright and have been able to compensate throughout their undergraduate careers, and this is something that really they've been able to manage until the workload becomes so high that, and particularly the organizational pieces of this. So is this a student who is really having trouble with the time management? Because that's particularly a challenge for many students as they move into the clinical phase, is there's not the regimented time frame. So are they having trouble critically thinking through things? Are they having difficulty prioritizing? In this student's case, actually, one of the challenges was that she really adored patients, and so she would frequently seek out opportunities to go see patients. She would stay late, and maybe wasn't really great at being able to prioritize her time and the ability to, like, I need to go home and study, because that isn't what she enjoyed doing as well. In addition, when you really sit down and discuss with a student, we also found out that she had a number of familial stressors. So her father was recently diagnosed with a chronic but terminal disease. She was providing primary care to that individual, had tried to move back home and was commuting back and forth, and there were significant family demands. And so when you think about this, how do you actually get the resources to be able to help the student be successful? Because these are incredibly challenging, and I think for most of our folks who are struggling, it's really hard to separate out some of these personal and social stressors from the academic demands, and keeping that in mind. So with this student, we really worked on some time management skills. There's opportunities, you can use a structured error analysis, so when they're missing questions and using some of these structured question banks, you can actually sit down with them and actually review the questions as to why they missed those questions, and really see, is this because they changed their answer and they lacked confidence, or is this because they were picking buzzwords, and really kind of help sort through that. Really important to also keep in mind that, again, even though these learners have made it this far, and I think sometimes we don't think about undiagnosed learning difficulties, that it's really worth thinking through that and being able to refer them to the resources that they need in order to help facilitate that. And particularly with our students, one of the things, again, as I mentioned before, because you are so incredibly siloed in your approach, unless the student is forthcoming in this, it's really difficult to actually know all of the information that's impacting the student. And you as the clerkship director may not know that information. And so really thinking about, how do you elevate that within your own institution? You could also just be a trusted faculty member that the student is working with, and they've really decided that they trust you and that you have their best interest at heart. And so it's likely that they're going to reach out to you. And so thinking about, how do you navigate this, either with the student affairs deans or with the curricular side, as to how to engage the resources that you need. Because what they're going to need to do is actually look at this in a more of a multimodal way. What's the information that's come to promotions committees? Do you have a feed forward process where they're able to actually help the students strategize, as well as being able to refer them to either counseling resources, Office of Clinical Skills to help them with simulation and other assessments, or to be able to refer them out for resources that they may need in order to help them be successful. And so, unlike, I feel like sometimes these cases are so incredibly frustrating, this student actually had an excellent outcome. I honestly didn't think this student was actually going to make it across the finish line, because there were such struggles leading up into that point. But her familial stressors were so incredible that once she was able to get those settled, that she actually went on to do incredibly well, passed step 2 without any difficulties or further delays, step 3, and went on to be incredibly successful in her career. So it's a beacon of hope to remind that really investing the time and resources in students, and the earlier we can do that, the more likely we are to have a beneficial outcome. And I am going to turn over to Dr. Patterson for the next case.
So let's move in and take a look at a resident. When we switch from medical students to residents and start thinking about remediation and capture and intervention, we have a new set of rules and guidelines that come into play. Some new resources, some old resources that are there, but a little bit of a shift in what we have to think about and access. This resident rotated in your shop as a fourth-year medical student. She was felt to be average in terms of fund of knowledge and just average performance on scores. Clinical performance slightly above average. Again, leveraging into really good interpersonal skills, liked her patients, followed them well. Residents felt like that they enjoyed working alongside her, would welcome her as a colleague, and faculty generally felt she was teachable. There were things to learn, we had work to improve on, but overall optimistic and teachable. And she matched into the program. As she began her residency, faculty began to notice some decline almost from early on, slipping a bit relative to peers. Peers seemed to be capturing knowledge, grabbing knowledge, moving ahead, while she was beginning to slip back a little bit. Others began to notice that she was disorganized. Patient presentations, evaluations were disorganized. Sometimes tasks were hard to get done on time or in the pressure time constraints in the department. She continued to be fairly well liked by her colleagues. She was hardworking, showed up on time, well engaged with that. But however, a full year into her residency, she wasn't making the progress she needed to make, and the slipping seemed to fall quite below colleagues, particularly in areas of medical knowledge and patient care milestones. And then faculty really had concerns about struggling with procedures. Initially, their concerns, because this person showed up on time every day, ready to work, eager to work, they chalked things up to anxiety. She looks anxious to me, and her hands shake when she tries to do a procedure. I'm worried about her anxiety in this space. So is there a problem here? I think for those of us who have really acclimated well to the milestones, they can be a tremendous tool for us for seeing differences in performance if we use them correctly, if we adapt them. We have a resident who's not where the peers are and not where we expect them to be. So we definitely have a problem. What problem do we have? That part's a little bit more difficult, and we need some additional data and information to do that. If we were looking at her like we look at with a patient, our differential's still pretty broad here, right? We've got faculty already speculating maybe she has anxiety. I will tell you folks throughout do we have a thyroid disorder problem here? Is there something medical going on with that? In a sense, we started to look at her like a patient and get distracted instead of looking at her like a learner and staying quite broad with that. Do we have medical knowledge deficits? Do we have somebody who doesn't actually want to be a physician in our space? Do we have somebody who has another problem that might be a little bit different? What's the goal of our remediation here? The goal of any remediation is and was for this resident to get them back to where they need to be. Are we back on track with an anticipated graduation date and performance at the baseline, whatever we've set, mid-range for our milestones? We know there are a set of helpful interventions. Again, picking the right intervention determines is imperative that we pick the right diagnosis first. Even though this paper is shockingly 20 years old now, I'm having a moment looking at that timeline, some of these are still quite accurate. More feedback. Do we know? Do we have more pieces of data to triangulate on this? More structured supervision. Is somebody actually watching? Does she ask the right questions? Does she listen to the patient, give us an answer? Does she ask the right follow-up questions? We don't know till we watch you. So some of those are the same thing. What's really interesting is that while it looks like it's not a high number there, formal evaluations for substance abuse and medical problems are still on that list. When we look at a model for remediation and we think about how we are doing this academically, not forgetting what's really already been published there, a multimodal assessment's at the top. Multimodal, are we looking at multiple problems at once before we begin to apply an intervention to this space? The intervention we chose with her is one I hope many of you in this room are familiar with, is beginning with a contract. And the contract for a remediation should have several parts to it. It's got to begin with a context description. It's got to be very much objective. Where are you? Where should you be? So here's the gap we're describing. This is the situation. This is the background for this. What are our steps in solution? The next step should be the multimodal assessment. assessments outside. So some of the things Luan referenced that are appropriate for students are still appropriate for residents, but let's replace the curriculum committee with a GME office, right? Let's head there, let's get what resources we have for educational assessments, let's get resources that we know internal to the department that you need to do, and let's get resources in our area that are helpful for you medically. Do I send you for a fitness for duty exam? To determine are you actually able to do these? Or do you have a neurologic condition and you can't do an LP? And then we have a different conversation. Maybe you're anxious around it. Included in in her multimodal assessment was also a mandatory referral in our state to a physician's health program that did comprehensive assessments for psychiatric and substance abuse problems. It's got to include a timeline. How fast do you have to do each one of these things, and then some consequences for not performance. And unfortunately, that terminal consequence is if you don't do it, you're done, and you've got to hold firm to that. So what outcome did we have for her? We began with multimodal educational assessments, a visit to a physician. Initially, we allowed her to visit her own physician instead of a fitness for duty exam. That's an error on our part. I will go ahead and acknowledge that. And we included, as I said, a referral to a physician's health program. What turned out was what we were not expecting, in that she had such severe high-functioning alcoholism. We had missed a lot of this because we didn't have some of what we were used to. Late to shifts, missing shifts, not showing up, that kind of decline. She managed to maintain all of that, but was clinically so intoxicated at the time of her assessment, the psychiatrist didn't realize it and called emergently to the program to say, I think you have a problem here. And what happened with that? We aborted our contract right then. Okay, we have a problem we didn't expect. Here we have clearly diagnosed what we know is the chief problem. If it isn't the only problem, it's the first problem. So we know where we're going with this. I will tell you, that it was a difficult assessment to begin. I'm sure many of you in the audience have had to deal with somebody who's impaired that way, but the outcome was honestly quite amazing. When we called this off, had a strong confrontation, and then sent them for inpatient care with healthcare providers, not other general public. We had a really, really strong outcome with that. It ultimately did mean leaving emergency medicine and a real confrontation that maybe the specialty was not the right specialty given their needs, personal needs to do, but still is practicing as a physician. If you look at substance abuse, and I think no talk on impaired or struggling learners is complete without it. Alcohol is still our biggest one, and we do have to acknowledge that while this case took place before the pandemic, this is on the rise, and we're likely working with multiple learners and perhaps some colleagues who are already suffering from severe or moderate to severe alcoholism. The closest link is with depersonalization, and I've placed in order the other substances that are associated with that. As a side note, it's probably a little hard to see from the type, but that bar on the graph at the top is the specialty with the highest incidence of alcohol addiction right now. I'll ask the audience briefly, can anybody read that? Yes, this is from the WMC, not us. We're not even the top three. Not that that's worth celebrating, but just acknowledging while we're struggling with this, we're not alone, and again, it's easy to hide. Just wanted to include that it's easy to hide. All right, let's take a look at another resident issue.
All right. Everyone feeling good? Yeah? Not worrying about the stuff that you're missing at your home programs? Not at all. All right, so let's go to another case. You have a fourth-year medical student who is interviewing for residency. He's looking great. His MSP looks fantastic. He's Q3 in his class, on his class rank, and that's okay. He's got some extracurricular stuff. He's class president. He's worked on the LCME kind of reaccreditation committee with his medical school. His step scores are fine, right in the competitive range. And his letters of recommendation don't seem to suggest anything scary or worrisome. You guys interview him. You like him, he's ranked highly on your list. Not terribly surprisingly, he matches at his home program. You would have loved to have him, but so it is. And he goes off to his home program. Then about a year in, you get contacted by him, and he says, hey, I want to transfer to your program. my program has hired a new program director, and I'm looking for a change. And you think, great, you have this unexpected opening in your program. Sure thing, we'd love to have someone that we already know, that we're familiar with, that we already know, that we really liked. You re-interview him, he's engaging, his interview's very nice. He again says the same kind of story about citing the new program director as his reason for leaving. He wants to participate more with his university, and that's just not something that the new PD is going to let happen. And he has great letters, right? He's got letters from the AAMC leadership that's supporting his case and his candidacy for a transfer to your program. And he's actually got this year-long kind of research gig that he might be able to step into in the meantime. Okay, so is there a problem? And notwithstanding that you're in a remediation lecture and you kind of assume that it's a problem, would this really actually be a problem or occur to you to be a problem if you're doing it in real time? And I see some nodding of heads. And I would say, yeah, absolutely. And my recommendation would be, if you're ever taking anybody outside of the match, you really got to be as skeptical as you could possibly be. What's going on? It's a big, big hassle, and it's a big pain for someone to change programs, to transfer, to move cities, to kind of pick up and learn a whole new system. So there's got to be a really, really good reason for someone to need to change and transfer programs to your program. So we're going to go on the assumption that there's a problem until proven that there's not. What other information might you need, and what's your differential for something like this? The differential could be gigantic, right? It could be nothing. The story could just really be legit, and he really might be unhappy with kind of the change in leadership, and it's time to make a move. That very well could be the case, but you need to know that, and you really, as a program director, you need to do your due diligence in these cases. There could be all sorts of issues. It could be patient care issues. It could be medical knowledge issues. It could be professionalism. It could be all of them, all of the above. Right? You really, really don't know. So what really should be your next step in cases like this? You need more information. You need to pick up the phone before you do anything, before you decide on a remediation plan. You need to figure out what's going on. So my advice would be pick up the phone and call their references, call their program director, call their APDs, call the people who are not his references, and make sure that you're getting an accurate story. So what happened when we called references on this person and got the backstory is, as you're seeing, he actually failed a rotation. He overslept the rotation, and when the chief resident went to make a wellness visit to check on him and why didn't you show up for shift, kind of found down in the bathroom. He was signing into the EMR. When he's not in the building, he's falsifying his procedure logs, and eventually did remediate his rotation and was not excused from the program, but he kind of saw the writing on the wall, and it was time to make a change. Okay, so that clarifies things quite a bit for us. Now we can start figuring out what's going on and what to do about it, but that really was the key information. Similar to what I tell my residents, when something doesn't make sense with your patient, ask more questions until it makes sense. Same thing on a troublesome resident. Ask more questions until the situation makes sense. Right. So the most frequently reported difficulties, the most often kind of things that we have to deal with in residency land and GME world as far as remediation goes are medical knowledge, which is kind of nice because it's the most straightforward and the most easily remediable. Patient care issues kind of come second, which is also maybe a little less straightforward, but also pretty easy to address, and there's lots of kind of good ways to go about that. The professionalism issues that are much more rare, fortunately, or the interpersonal communication skills are more rare, but they are much more troublesome to try to remediate. If you are starting to kind of get worried and sweat a little bit about how am I going to figure these out, how do I find these? Well, this is it. Your chief residents easily are your most valuable resource. You pick them for a reason. Rely on them. When Now, they won't always be accurate. They won't always, not everyone they bring to you will need a full-on remediation, but in my experience and kind of in this literature that we're able to find, oftentimes the ones that do become troublesome and do need remediation start through a chief resident bringing it to you. The number 2 most common there is the beloved or dreaded hallway conversation with one of your faculty. Hey, Mike, can I get a minute in the hallway? No, I'm trying to sign out. Can we do it? Okay, fine. Right, so doing that kind of in the hallway conversation actually is quite valuable, and faculty are not as prone to put it in writing for whatever that is, whether they don't like dogging someone on a written evaluation or having it traced back to them. They're just more likely to put it in a verbal interaction rather than a written evaluation. This is similar to what I just said. Medical knowledge, definitely the most common remediation. However, but also the most easily remediable. Professionalism, much less common, but much harder to remediate. Definitely the easiest way to remediate professionalism is to not have to deal with it at all in the first place and to do your due diligence when you're deciding on people to join your program. So we'll kind of go through there. Written evaluations. You really got to get on your faculty and get on them early. You need written evaluations. Sometimes it's not just the one faculty want to. I don't want to get anyone in trouble. Usually you're not going on a remediation plan for one bad evaluation, but it's usually the confluence of a bunch of evaluations and a trend towards something that's concerning. All right, let's go on to our next case.
So our last case is going to shift a little bit from attendings to residents. And I'll ask the audience, how many of you have a position of leadership in your department somewhere, whether it's a director, assistant director, clerkship director, PD, something like that? A few tentative hands go up. Okay. We're going to take a look at an attending who is having some of the same difficulties maybe that we see in residents, different problem source, and how we attack that. So B is a senior attending physician who's worked approximately the last 10 years in a level 1 academic medical center. In that time, the shifts have been predominantly teaching shifts, right? At most academic medical centers, there are a few places where you work without learners, maybe conference coverage days, maybe a fast track, maybe not. But the majority of this person's work was with resident shifts, regular teaching shifts. Post-pandemic, as patterns have shifted and changed and needs have shifted and changed, additional non-teaching shifts, clinical shifts have been added in several spaces. B's assigned to some of these shifts and before you realize it, has really expressed their frustration to schedulers. Then you start to see some concerns and complaints coming in an official capacity. Complaints from the patient's experience office who says, hey, we're getting complaints from family and patients themselves. Pharmacy has questions and concerns about orders they're getting or not getting around patients who should be following the sepsis protocol. And the surgical service comes to you and says, why does B keep consulting us emergently down to the ED to repair things other people don't? Why is that happening? Do we have a problem? Well, anytime you get multiple complaints in any leadership position, you have a problem. Whether the person's the problem or not, you now have a problem in your space. And how can this be evaluated? What's the root here? Do we have an actual problem with this person? Are they declining? Is this a change in behavior or practice and pattern? Are they okay? Are other people just not used to now practicing with a senior physician as opposed to an intern or resident that maybe they speak to differently? Is this just a difference in style? What's the differential here? It's not really clear from this narrative, but this is a change in behavior, and we always think about impairment, whether that's substance or psychological, when we see some change in behavior. I will tell you for the sake of time in this case, we could put that on the differential, but we're not going to dive deep into that. What options are out there once we determine what the problems are, or what that problem is? So we need data, and it's a little bit different for attendings than it is for medical students, but some of this same can apply very clearly to residents. So first and foremost, sit down and use the peer review process that exists. Take the cases, send them for peer review that you've had complaints and concerns about, particularly things from pharmacy questioning deviations and typical patterns are a great place to start with that. Another place we took a look at, since many of the concerns started to arise around procedures, and effectively we're questioning whether or not this physician could do some of the procedures typically expected of a credentialed provider. So using billing data to actually count, let's look at the last 3 years, and then let's look at a 3-year average from your peers. How many procedures have you done? How many procedures have you supervised and signed off on? And then peer performance comparison data. This is a little bit different than using data like the aggregate data many medical directors look at on how quickly does someone get in a room, what's the door-to-doc time, what's your overall throughput time, how many patients per hour are you seeing? Because when you're working with residents or you're looking at it in aggregate averaged across, it's not really clear. If instead you take the shifts that are all now non-teaching shifts, same day, same time, and compare B to other attendings, you get a picture of comparison data that is a little bit easier to look at. Is this person, for example, less likely to get in a room of a critical patient and more likely to let the physician partner get in that room of the critical patient? Do they see fewer patients then? Are they consulting more than their average there? And then sitting down for a period of self-reflection. I think reflection belongs in every one of our remediation processes, but in an adult physician, this is a peer-to-peer reflection with either your medical director, division head, chair. And when there's some differences, simulation can be a great tool for both diagnosis as well as education support. What does that simulation look like? Well, in this instance, we took the aggregate concerns relayed that we said, yep, through peer review, we can see some concerns, we see some deviations. You are telling us that these are practice style deviations, not core deviations in abilities and skills. Let's take those scenarios, let's take those conditions and concerns that have been relayed, the peer review cases themselves, and let's use simulation to create a series of scenarios, not unlike we do with residents. Here are the scenarios based only on the concerns. Recruit some peer evaluators. I will tell you of this, that was the most challenging part, to get the right peer evaluators to do this work. Take a look at analogous milestones. What do we expect out of an attending? That's somebody who's at a milestone 4, right? Ideally a 5 if we're 5 years out of practice, but 4 to 5s. What is that? What are those guidelines? How would we use a checklist using those guidelines and then apply it to faculty? And then there are considerations here of due process or not. In this particular person's case, we use this only to say, let's do this and see what you can do and then discuss afterwards, and then we'll make a plan. We currently, in our due process guidelines, do not have protocolized or in policy form ways to utilize this outside of new credentialing. We have a pathway in new credentialing, but we don't have it outside, so we couldn't use it for a due process action. Can use it for a due process action. Definitely could use it to inform and engage in some discussion. What did we do with B? We went through a simulation exercise and then had another reflective discussion in which we decided that the right practice environment was not full EM procedural credentials, and that perhaps would be a limited credential, not unlike somebody who might work in a fast track or an area that sees no higher than acuity 3 and is not required to do invasive procedures. Following this, we're then taking a look at all of our policies and processes internally, because what was our actual diagnosis here? I'll tell you, it wasn't substance abuse, it wasn't impairment in any way, but what we had was some skill attrition. And in discussion with clinical chairs and leaders around skill attrition, something we are seeing more and more of, and we need to take our educational processes and apply them to that. So we are beginning after this case to then look at policy and process standards for our own department. How often do we report to faculty much more data about their own performance? We would never assume, or maybe never assumed 15, 20 years ago, that any of us would forget how to intubate somebody. And yet, if we're training the residents really well, we might. So how many intubations have you done in the last 3 years? How many critical resuscitations have you done in the last 3 years? Hi, it's your annual evaluation. You haven't done any in the last 18 months. You have the option of going to the sim lab. Here's some educational option open to you for refresher for yourself. We're charting it. We're now at 3 years and you haven't done any. Now I put a process into place where we use simulation a little bit differently. So we wanted to share that case with folks because we're still using a lot of what we already know how to do with residents and students and applying it in the right context to our senior colleagues. So just in summary, why do we fail to remediate? Why do we fail to engage in this even now with so many tools that we have? There's still places and spaces where our behavioral standards could be better identified. And if we have a solid metric, we have a solid yardstick, we can measure much better. And if we measure regularly, we move towards that. We always move what we measure. There's still good evaluators that lack the knowledge of what it is they need to do. We have new faculty join our department every year. There's always more room to put more onboarding effort into getting people ready to do the job we hired them to do. We still see faculty evaluators of all stages across the curriculum unwilling to speak up with early warnings, motivated out of really good intentions. This person's having a bad day. They're having a bad day. Yeah, they're having a lot of bad days, and we have to recognize that. And ongoing fear of legal repercussions. We've referenced a couple of different places here where we've utilized processes in the institution. Policy and process are always your ally in this. If you follow your own policy, you have a lot of support and protection from your institution. Over the last several years, as we've been exploring kind of different topics on this talk, we have seen a rise in the number of folks struggling individually and collectively across the continuum. And earlier intervention improves those outcomes. So at this point in time, we do have a few minutes, I think, probably not quite 10 minutes for questions. We have microphone on in the middle. We can bring it to you, or you're welcome to come to the front, but we'd love to take questions from you guys.
Hi, thank you. My name is Nick. I'm a pharmacist and a learner. I wanted to ask a question about the process of diagnosing a problem and going through the differential. You know, as a pharmacist, it's not my job to do differential diagnoses and collect histories. But one thing that I noticed was kind of missing, I guess, from the framework was, you know, there was like the kind of sick, not sick question. Is there a problem? What else do we need to know? And then what's the differential? But in none of the stories I heard that there was a direct conversation with the learner or the person of interest. At what point does that come in to kind of strengthen the educational alliance and in general, I guess, just hear from their perspective what's going on?
I'll start with that. So I think for me, the discussion with the learner is actually one of the very first conversations that you have. It's the moment that you notice that they're struggling, because I think one of our challenges really is that we are so aligned with the learner that we do have a tendency for this. It was just a bad day. I don't want to document it. It might impact their career negatively. I don't want to give them a bad grade just because of one day. And so to me, it's really about engaging the learner from the very beginning aspect. I think one of my real challenges from my position is it is so challenging because of the perceived threat on the learner's part to be able to get them to engage with the resources that really could aid and assist them. We've seen, you know, there's stigma around mental health. People don't want to get the counseling resources that they need. They don't want to go and seek out support. They're afraid that somehow this is going to end up in their MSPE or in their letters of recommendation. But I think you really can't actually begin to develop a plan without the learner at the table. And you really hope that they're a willing participant, because together we can actually accomplish so much more than when there's the fear of stigma or repercussions. I mean, it's never my goal to sit there and like punish people. We really do want to help people. And so really being able to convince people of that, our learners of that, no matter where they are in the continuum, and really help them understand that we have their best interest at heart. One of the challenges though is, I think ultimately there are potential adverse outcomes to come about. And so now I think the earlier you can also build a relationship, it's harder on our part for an adverse outcome, but I can at least sleep well at night knowing that I have done everything possible. And it frequently takes multiple meetings with really engaging multiple resources in order to be able to get that information to come out.
Yeah, so I agree. An early conversation, once you kind of understand what the problem is or what's being presented, then usually my very next action is to talk to the resident involved, usually in my case. So, and I actually have had a successful approach with approaching it still from a perspective of alignment with the resident. And almost always really my first question is, hey, here's the feedback that I'm getting. How are you doing? Are you okay? And usually, I mean, more often than not, the waterworks start and it all comes out. And my relationship is falling apart, or my parent just died. I'm living on the other coast from my significant other, whatever it is, the stressor that is affecting this person's life, that is preventing them from thriving and succeeding in your program. And that is much more kind of readily dealt with, rather than, hey, you are not doing your thing, you're not meeting your milestones, why are you being a bad learner?
Firstly, thank you very much for putting this together, especially for attendings, because I think that's one of the areas that we learn about learners and medical students and so forth, but I think, thank you very much, this is very helpful. So it's a two-part question, I apologize. So the first one is, how do you protect confidentiality, particularly of an attending, right? And then the second part, I like the idea of pulling the billing data, but how do you structure it such that, in terms of remediating, particularly for like HALO type procedures or high acuity, low opportunity, how do you schedule that? Like, do you plan this up way in advance so that people know it's like, well, we have something similar in our programs every 3 years that we do airway, but now looking at this, I'm thinking like maybe art lines and so forth. So do you have a recommendation on those two things? Thanks.
Sure, thank you. So the confidentiality is a huge piece of this. We've done this 3 times in the last couple of years, and it's not a role for everybody, right? So somebody who's in the first 5 years out, this is not the right role for them to come in and step into it. So my vice chair and I speak to people directly about this. I've been very impressed with faculty's professionalism approach to it. In at least one of the instances, I think the faculty engaged with it felt that it was the right thing, but were really heartbroken for their colleague watching someone struggle and have to confront the struggle in that space. But you sit down and you have the conversation, this is what we're doing, this is 100% confidential. We have a good relationship with the simulation lab, just from some functional aspects, scheduling it outside of the lab regular time when there are no students in the space at all, there for other reasons. We recruited nurse from the department who'd been working with our residents in their simulation time and just had some really good, had a really good approach and behavior, and was not working in the same clinical space as at least 2 of these people. In that you can outsource it. I will tell you, if you have to outsource it, it's expensive. So for those of you who are overseeing that part, there are few places that'll do this, but it's expensive. So I recommend you do it in-house. If you have a network that's got more than one ED in it, grabbing staff from that's a really good approach. Billing data was not so hard for us. Just for those of you who use Epic as your medical record and have access to Roundtable Analytics, I would absolutely call them and ask them for help, because the comparison, point-by-point comparison of what you want to know, let's say you have 5 people working in a fast track, they can get you some real hard data for that. Yeah, and was that all of your questions? Did I hit the points?
Scheduling.
Oh, scheduling it out. 2 parts there. So for the high acuity, low interventions ones, we're still working on that. And our approach is going to be quarterly content for faculty that's optional, with a timeline of when you haven't hit your, timely metric of, okay, you haven't taken advantage of the optional ones, and now we're at a place where I now mandate with that. Yeah. And we probably, I think maybe can do one, well, yeah, we have time for 1 or 2 more.
Thanks for a great talk. Also on the attending front, I think that it's a really important thing. The hospital often cares about minimal standards of competence rather than the department caring about somebody being really, really competent and able to care for patients effectively. From the due process standpoint, one question I had specifically in your case that you presented was oftentimes peer review is viewed as a little I investigation, but once you start talking about restricting someone's credentials or privileges, that becomes a capital I investigation, has a window, has and once you do limit their privileges, has a 28-day report or mandatory reporting to the NPDB. So how did you guys avoid that in that case? Was that a conversation with this person to say, hey, electively you need to do this, or how did you navigate that?
Right. So, we're live streaming, so, so let me be gentle here. There's more than one person that maybe fits that letter B, and more than one option. The best option was the deep reflection, not unlike what we would have with learners, to say, okay, we're not where we envision ourselves to be if we practice with the full privileges for full active scope of practice in emergency medicine. We have had precedent with faculty for other reasons who restricted their scope of practice voluntarily. Our two we have senior deans who, have stepped back. They're 95% somewhere else, so they no longer work in high acuity setting. They voluntarily stepped back. We can do three things. We can put you on a formal remediation structure such that we aspire to get you back. We can allow you to voluntarily restrict your privileges to something that looks more like a fast track. At our institution, we do have 2 grades, but we also have a non-punitive option for restricting. I would like to step back in my clinical work to this. That was chosen by one of those folks and was really probably the best outcome in that, because we could have implemented a set of guidelines using some external resources, internal resources, but the cost was going to be high. So the other person is what really generated let's approach this process-wise so that we are sure in the future anybody else who encounters your space, we've caught it beforehand to capture it, to help you, but then we've also got the due process in place for it.
I'll just add on as one extra piece of that. I think no matter where you are along the continuum, I would encourage you to involve legal, particularly when you anticipate that there are going to be adverse actions. So, and I think it's important to involve them throughout the process, particularly I think with the professionalism issues, because those are typically high stakes. They're typically other professionalism issues that come about. And so in my current role, I serve as Senior Associate Dean for Medical Education and Student Affairs. And if there is a large issue, I automatically call legal actually as one of my first starting points, just for clarity around that point. The other thing, though, I think it's been really important to engage legal in the writing of policies, because there's some things that we do that we are trying to be learner-centered that create legal implications for us. So I was writing a new promotion and an advancement policy, and I incorporated in there that, if the learner wasn't functioning or there were safety concerns, that we were going to put them on a mandatory leave of absence, because that felt more nurturing to me. They were like, no, you suspend people in those. And so really thinking about the verbiage and engaging them has been incredibly helpful.
I would agree with that. The first 2 years of my career, I was deathly afraid to talk to any of our attorneys. I had malpractice confabulated with the other work, and not really realizing they're my attorneys. They work for us. This is wonderful. And so, yeah, I would echo that they. I have not met one yet who worked for the institutions that did not give sound advice from a procedural aspect. Yeah. I think we're just double checking, wanting to respect the time. If there are no other questions, we'll be up here for a few minutes, but thank you all very much for your attendance.